from biportal we come to the uniportal full endoscopic module. I would like to invite my co-moderator, Dr. Sandeep Sonone, and panelists, Dr. Fani Kiran and Dr. Nidhi Kumar Patel, please. Please, if you can come on the stage. Can we have the... So just to an introduction to this module, uniportal, we have various approaches. So you can go interlaminar, we have transforaminal. Now, for example, if you see this case, this is a L34 huge central disc. Patient had a left-sided leg pain, and along with that, he had a foot drop as well. Now, as we all talk about, but in the end, endoscopic surgery or minimally invasive spine surgery is basically you try and do the least and gain the maximum advantage. Now, whether to use an interlaminar approach here, where I probably will need to remove bone, or should I go in transforaminal, which makes it the least invasive? So is there any way? So in this module, we will discuss that whether are there any algorithms available for us to decide whether we go for transforaminal or interlaminar. Now, similarly, you have a L5S1 disc on the left side, but then you have L5S1 superiorly migrated disc. Again, questions are what approach to take. Now, also, there is a lot of debate on what kind of scope to use, because in the uniportal, we have 4.3 mm working channel scopes for interlaminar. You have longer scopes for transforaminal. You have stenoscopes, which are 5.7 mm working channel, 8 mm working channels. So there is a lot of confusion. So we'll have speakers as well over here who will tell us what kind of scopes to use, what do you do for a posterior cervical foraminotomy, what do you do in cases where you have higher level discs like this, where it's a L2, 3, say an inferiorly migrated disc, do you use the transforaminal? Again, for decompression, when do we stop? How much bone do we remove? When do we say that you have decompressed the nerve clearly? When do we say, okay, I'm done with my surgery? So I think through this module, we will try and discuss all these points and bring out all these points. So with that, I would like to invite our first speaker, Dr. Tanmay Avadh, who will be telling us about an algorithm for selecting a full endoscopic approach. Do we have Dr. Tanmay here?
Hello, good morning everyone. So today we'll be talking about selecting the full endoscopic approach for the symptomatic nerve root decompression. So basically we generally encounter this. We have a patient with a right S1 radiculopathy. We also see that it's a L5S1 right paracentral herniation. So one question which bothers all of us is which approach to take, transforaminal or interlaminar. The paracentral herniation, a superior migration, also an arthritic facet, sagittally oriented, also an L5S1. So will it be transforaminal or interlaminar? So there are a lot of factors which help, which determine the approach. We'll know about it in the future, in the further slides. First thing is to have a proper clinical diagnosis, whether the herniation is on the right or the left. Compare it to the dermatomal distribution of the pain. Make sure you have the correct side as well. Location is the utmost priority. Whether it's a paracentral, superior migrations, you're talking about whether there is a factor other than the anterior pathology, the posterior pathology, a lot of things, and exactly where it lies in the patient's level. That is very crucial to determine. First, understanding what do you see at the level of upper discal margin. This is the upper discal margin cut on the axial cut. You want to see the exiting nerve root. You want to see, is it being compressed by the tip of SAP, a posterior component, or a foraminal or an extraforaminal herniation as well. So understanding every cut in the axial MRI is essential to make sure to understanding the pathology in a more clearer way. Then we want to see the middle of the disc. Now you would want to start seeing the traversing nerve root, which is more over the medial third of the SAP. You want to see whether it is compressed by any herniation or any flaval component as well. And at the lower discal margin, also you would want to see whether there is any compression over the traversing nerve root and by the SAP or the flaval. So understanding the approaches and their limitations is very important in both of them. So when you are accessing transforaminally, you know this is the area which you can decompress, the foraminal, the extraforaminal, also the central part, which is more ventral rather than dorsal. This is the axis which you're going to get. Secondly, from an interlaminar perspective, this is what you can access, which is the ipsilateral side. Also, very important, with the help of ICLF, which is contralateral decompression, you can access the other side foramen as well. So this is basically the gist of what you can approach with both of these approaches. This is where the concept of endospine 360 comes in, where you can access all the parts of the pathology by a combination of transforaminal and interlaminar approach. Now let's just go towards how to decide which approach. So it's an MRI-based surgical classification which we have devised along with Dr. Prasad Padgaonkar sir. We published this in 2023. It's basically understanding the pathology and the targeted intervention which is going to require. So we have divided into a right L4-5 fab disc, which is for the L4-5 motion segment, and similarly on the left side as well. So this is the algorithm which is a fab disc, which we call it, which is facet inclination, anterior compression, posterior compression, dorsal migration, inferior and superior migration. So let's talk about facet orientation, which is F. We have divided the orientation into 4 parts, which is F1 to F4, based on sagittal to coronal orientation. Next would be, depending upon where it is oriented, how it is oriented, the approach would be decided. Second is anterior and posterior nerve root compression. Understanding this is very important, whether there is a discal component or there is a posterior component. Understanding whether the flavum is affecting the foraminal or extraforaminal region as well. We've given points for these as well. Secondly, and you can have 2 components also, like A2, A3, a central and a paracentral component as well. Similarly, posterior component is also divided at P1 to P4. Secondly, then comes the migration, the dorsal migration, the inferior migration, and the superior migration as near, far, and very far. So all of these points have been given specific marking schemes as based on this thing. So whichever you have a fab disc calculator, which we use on our website as well, where you can put on these findings and you will get a score. Whichever score is more, this is the approach you will be taking. So let's just go over this one case where we have a patient with a left L5 radiculopathy. This patient has a facet angle of type 2, anterior pathology A1, A2, no posterior pathology and no migration. Hence the transforaminal to TF to IL score is 5 to 4.5. Hence we would go for more towards a transforaminal approach. This will be more ideal for this patient. Hence that would help us selecting the approach more, so that we don't fall into any other complication by selecting a wrong approach. Similarly, we have a right L5 radiculopathy with a MRI showing more of an with a facet angle which is more of coronally oriented.
Can they conclude, please?
With a anterior pathology and a near inferior migration. Hence, we would go for an interlaminar approach, which will help us to address the problem without landing in inadequate decompression. So, and this is a surgical classification which we want to make sure that every young learning surgeon does adapt, so that he would not end up into any problems which most of our seniors have gone through, and help us in the better patient selection. Thank you.
Thank you. Thank you. I think we'll take questions. So I'll request the speakers to hang around here.
Yes.
Once all the talks are over, we'll do the whole discussion at the end. So we now invite Dr. Warawat to talk about full endoscopic decompression. How much space do we need?
Thank you. My name is Warawat Limthongkul from Chulalongkorn University, Bangkok, Thailand. So I have a great pleasure to present our study. So normally when we do endoscopic decompression, mainly I did the interlaminar approach. Thing is, we have a good clinical outcome, both lateral recess and central canal. But when we looked at the MRI, success rate is about 91.4%. 91.4%. How about all the 9% left? We think there's some sequential things that we have to look into. When we follow up and do the MRI, there's still some lateral recess stenosis, even though the clinical is okay, but we never know what's going to happen next. So that's kind of like what we want to study, and we want to look at how can we get a good clinical outcome and radiographic outcomes. What we study is that we measure the distance between the lateral, medial facet to the nerve. What we use is, we did a prospective cohort study from January to December, and we calculated the number of the patient, which is 68 patients with a single lumbar level stenosis, lateral recess stenosis. We did measure using the probe, which is 3.5 millimeter, that we set it as the cut point. And as we know that Hasegawa did a study on 1995 showing that if the lateral recess is less than 3 millimeter, that may cause some evidence of the clinical stenosis. So we use that number as our cut point if that's adequate decompression. So we did measure the clinical results using the WATS, back and leg, and ODI score. And also we did measure the MRI of the lumbar spine at 6 months, and we correlate both clinical and radiographic. Results demographic data is both groups are similar. We got more females, and the grade 2 stenosis of the lateral recess is the most, and we did the most surgery in the L4-5. What we found is the VS back comparing between less than 3.5 millimeters and more than 3.5 millimeter are the same. Also, VS leg is not significant different. However, we see a little shift downwards in the lateral recess that we can decompress more than 3.5 millimeters. And also the ODI score shows similar to the VAS leg, so shift downward but not significant different. MACNAP criteria and MACNAP score show all good and excellent clinical results. In the radiographic outcome, MRI shows significant difference in the improvement of the lateral recess stenosis between both groups. And we found that if we keep a space more than 3.5 millimeter, the improvement in the MRI is a lot better, significantly. Our limitation of this study is that the patient number is small. We get only 68 patients divided into groups. Some selection bias is always there because this is a prospective course design. And we limited that follow-up until 1 year, even though that's not clinical significant because patients can still get a good results, but we never know that more than 1 year, what's gonna happen if we didn't have adequate decompression more than 3.5 millimeters. So our conclusion is that the intraoperative space between the nerve root and the medial part of the facet joint should exceed 3.5 millimeter during the full endoscopic decompression to ensure that we get both good clinical improvement and radiographic outcomes so that this wouldn't come back and compress the nerve again. Thank you.
Thank you. Now invite Dr. Pushkar Borole, please, to talk on multi-level endoscopic decompression for herniation and stenosis on a novel algorithm.
Start. Very good morning, everyone. I am Dr. Pushkar Borole, from spine surgeon from Endospine 360 team and Deccan Hospital, Kolhapur. I am presenting our work on multi-level endoscopic decompression for lumbar herniation and stenosis based on FEBDIS algorithm. So lumbar disc herniation and stenosis often present as a combined problem in different stages of pathogenesis. This results in symptoms like back pain, radicular pain, and claudication. There remains a controversy on how to treat multi-level lumbar stenosis, and we have options like open laminectomy, fusion, MIS, endoscopy. Due to small skin incision and minimal tissue damage, endoscopy offers a good alternative for decompression in case of multi-level lumbar stenosis and herniation. So we studied 100 patients retrospectively with multiple multi-level lumbar stenosis and disc herniation who underwent transforaminal and interlaminar decompression based on FEBDIS algorithm. A brief description of FEBDIS algorithm: facet Inclination divided into 4 types. The anterior and posterior pathology again classified in 4 types. Dorsal, inferior, and superior migration as shown in the figure. So a transforaminal and IL interlamina. So TF and IL scoring is given to each offending pathology based on which approach is better to deal the pathology, deal with it. So adding all these scores, we get a final TF and IL score, which suggests which approach is best to deal with these combinations of offending pathology. So these are our inclusion and exclusion criteria. We calculated VAS score for leg and back pain pre-operatively, post-operatively at 6 weeks, 6 months, and 12 months. And ODI score was checked pre-operatively and 6 months and 12 months post-operatively. We operated total 223 disc levels, 142 were transforaminal endoscopy and 81 interlaminar endoscopy was done. 90 patients underwent 2-level decompression, whereas 10 patients underwent 3-level decompression. 88 patient underwent a single-stage procedure, whereas 12 patient underwent a 2-stage procedure. These are our operating timings. There is a significant improvement in VAS score of back pain and leg pain. Good improvement in ODI score as well. Our complication rates were around 5% with a recurrent herniation of 2%, dural tear, single case of temporary quadriceps weakness, and 1 case of instability. Coming to cases, this is a 49-year-old lady with low back pain, left lower limb pain since 12 months, neuroclaudication 500 meters, no motor deficit. On MRI, we can see that there is a L3, L4 bilateral lateral recess stenosis. L4, L5 left more than right lateral recess stenosis. L5, S1 left paracentral herniation. So we went transforaminally for L3, 4 level. So transforaminal endoscopic lateral recess decompression was done. We can see pre-op and post-op MRI. Interlaminar decompression was done for L4, 5 and L5, S1 interlaminar discectomy was done. These are the clinical pictures. Another case of 40-year-old lady with low back pain, bilateral lower limb pain, right followed by left since 18 months, neuroclaudication 500 meters, no motor deficit. On MRI, we can see at L3, 4, there is a bilateral paracentral herniation, L4, 5 bilateral lateral recess stenosis, and L5, S1 right paracentral herniation. So for L3, 4 level, we went, for this lady, we did a staged procedure. Bilateral L3, L4 transforaminal endoscopic decompression was done. L4, L5, LULBD over the top, ipsilateral and contralateral over the top decompression was done. And discectomy was done for L5, S1 right side. This is the clinical picture. So FEBDIS algorithm offers the safest and easiest full endoscopic approach selection for targeted symptomatic nerve root decompression. Thank you.
Thank you. We now invite Dr. Ravindranath Komi.
Thanks to the organizing committee for the invitation. I must confess I'm a pure transforaminal endoscopic spine surgeon, and since a decade I've been doing transforaminal surgeries. And I give you my aspect of dealing with all the problems through the transforaminal window. These are general benefits of any endoscopic surgery: reduced tissue damage, blood loss, reduced blood loss, better visualization, and all of them finally aim at a better functional preservation of the spinal segment. And other beauty is that all these procedures can be done under local or an epidural anesthesia, and if the patient is not very cooperative, we can do a regional anesthesia as well as general anesthesia. Now I'm going to highlight basically the advantages of this technique on some case scenarios where we deal with the different type of disc herniations, whereas some disc herniations are more difficult to be dealt than most of the other easier ones. Calcified discs, foraminal stenosis, and endoscopic assisted fusions. The disc herniations, my focus is mainly on extraforaminal and foraminal discs, because these are the discs which are it requires a little more elaborate dissection, more elaborate procedures if you are open spine surgeon or using a microscope-assisted surgery. Whereas through a transfemoral endoscopy, this becomes a very easy surgery. I may not say it's a very easy surgery, but over a period of time, it becomes very easy to operate these cases under local anesthesia. And because these fragments are right in the path of your scope, so these fragments can be very easily removed. Similarly, to deal with the migrated herniations, either superior inferior migrations or even dorsal migrations. There is some aspect of annular ruptures where we see a HIZ, where it can be beautifully dealt with transfemoral scopes. And the upper lumbar levels and thoracic discs, again, for an open spine surgeon, this might be a nightmare, but whereas for a transfemoral or for an interlaminar surgeon, these problems can be solved in a very easy way. Now, coming to the extrafemoral disc, you find L4, L5 disc, and you land on the lateral pedicle line. You put your instruments in, and the disc fragment is right in front of you. You just have to remove it without causing any tissue damage, any bone resection. Patient is comfortable under local anesthesia. You can get him down the operating table and make him walk as well. So that's so easy. It's like going to a dentist basically, and finishing your work and going back home. Another difficult procedures, what I must say, is the migrated herniations. Now here is one extraforaminal up-migrated disc herniation at L3-4, and this is a doctor from Bangalore. And I did under local anesthesia, and again with the transfemoral approach, and this can be very easily removed. And there are some instruments which help us to do that. Is a flexible grasper, and of course there is a hook which is designed by Dr. Gore himself, which helps us in delivering these fragments. Superior migrations, again, now you can see the fragment almost extending up to the upper disc level, but even then these fragments also can be removed through a transfemoral route, and the instruments which help you in removing it. These are not to be done by a beginner, of course, but then you need a good number of 30 to 40 surgeries to be done on a regular paracentral centered disc. Only then you can try to attempt to do these surgeries. Inferior and dorsal migrated disc, again, the hook can be used to deliver the disc fragment into the scope's view, and you can remove it very comfortably. This is one case which I operated very recently. A young guy with 3-level disc herniations. The upper 2 levels, the D12, L1 and L1, L2 are calcified, whereas L4, 5 is a soft disc fragment. He had bilateral claudication symptoms, and I performed the surgery on consecutive days. The first day, I took him on for L1, 2 and L4, 5 on the right side, whereas on the very next day, on repeated analgesia again, I performed the D12, L1. Now you can see the plate of a calcified disc at D12, L1. These tissues can be removed. Yesterday, even Dr. Sukumar displayed. I have a video on this. Maybe if time permits, I can show you in the end. Stenosis. This is the area where I feel transfemoral and interlaminar are more complementary to each other, because through transfemoral we can always deal with the tissues which are anterior to the nerve root in the anterior epidural space, and femoroplasty is the procedure where we drill a part of the facet, then go on to the superior articular process, and we target the ligamentum flavum, which comes all the way up to the base of the pedicle, and there's something called the G knot, which is over the axilla at the tip of the superior articular process. All these tissues can be dealt through transfemoral, and this helps in sort of decompressing both the traversing as well as the exiting routes, whereas the ligamentum flavum can be better removed with interlaminar or the posteriorly. And we have one more newest introduction where if we find a collapsed space, we use Vajra, which is the interbody spacer. There's a femoroplasty, there's a fusion, transcameral fusion, which is gaining more popularity nowadays, and transfemoral can be used to perform these procedures as well as a transcameral fusion for reticulosis L4, L5. And this is a game changer where 5 mm rod can be sort of jacked up to a interbody spacer. That's from 9.5, it's a lordotic cage, which we can use for the transfemoral route. It can be used alone as a interbody spacer also, with a transcameral fusion as well, and using the principle of indirect decompression. And it can be used from both sides, biportal, with or without screws. And this is one of the follow-up of 18 years. This is Dr. Gore's slide, which he had performed this surgery on 18 years back, and this implant was not available, but now recently, last month, we have started using it again. Now this is manufactured in India now. So summary-wise, full endoscopy techniques, they are truly minimally invasive, and both are complementary, whereas transfemoral can be used at all levels. Most of the herniations, where interlaminar can help in L5S1 as well in stenosis. Thank you.
Thank you. Now I invite Dr. Bhupesh Patel, who will be talking on does the choice of scope matter in endoscopic decompression.
Size always matter, whether it's scope or somewhere else. So today we'll talk about this. Does the size of the scope matter in the transfemoral or endoscopic spine surgery? Again, our main objective are what are the different kind of monoportal scopes available in the markets? What are the indication according to pathology? How we easily maneuver, because when we are in the interlaminar space, we have a limited space available. So how easily you maneuver the scope to reach the pathology, it is very important. Again, which segment of the spine you operate, whether it is thoracic, cervical or lumbar spine. Last is the most important cost factor. The transforaminal scope is available in 6.9 mm outer diameter because of anatomical constraint. So, but inner diameter is up to 3.5, 3.7, 4.1, 4.3, depending on the company or scope which is manufacturing. Interlaminar scope, outer diameter varies 8.4 to 10 mm or 9.3 revoscope available. Again, IDs vary from 5.7 to 7 mm or 5.6 mm. Again, Revo has only discoscope, shorter scope for interlaminar endoscopy, again 6.5 mm outer diameter. Length is for 180, starts from 180 to 207 in transfemoral scope. Again, interlaminar scope 110 to 170. Oval and round working channel, all the different, everybody is available. Again, but very important point, larger the working channel, the smaller scope lens. So optics are very small when you use a large working channel scope. So the vision are not that good. So when your scope lens diameter is around 2.1 or 2.7, the optics vision is very good. Where the size matters. Here transfemoral scope, we don't have any option because of anatomical constraint. But when the disc herniation with large interlaminar window, especially at L4-5 or L5S1 or sometime L4-5 also has a large interlaminar window. So if you see the L5S1 ipsilateral 16 millimeter window, so your smaller scope, 6.9 or 9 millimeter scope easily go. You can just need to split ligamentum fleum around 5 to 7 millimeter and just go to the shoulder and remove the disc. It is very easy job. But when you use the stenoscope in L5S1 especially, you need to remove a lot of ligamentum fleum because scope size is very large, around 10 millimeter. So you have to create that much of window in order to go into the epidural space. So here again, scope size matters. You see this is a video. So with retraction, smaller scope, your cannula can with your cannula you retract the root and you can do aggressive discectomy, which is not possible to stenoscope with a working sleeve because every time you are traversing nerve root is all the time in the waist. So you are always fear of damaging nerve root or grabbing the nerve root. So smaller scope here matters a lot. Second, the higher level disc herniation. So what I suggest here, the interlaminar window is very small and stabilizing structure, facet joint are very near to each other. So here initially you can do drill with a larger scope and then move to the smaller scope once you go little deep into the interlaminar window. And just because when you are using larger scope, to accommodate the scope, you need to remove more bone. So you end up with the damaging the facet and create the instability. Again, root retraction is not easy with a larger scope in higher level. So I would suggest smaller scope in upper level. Contralateral work is very easy with a smaller scope because you can go below the lamina very easily. But disadvantage is time consuming because of smaller instrument. Again, posterior cervical endoscopic discectomy. Bony lamina is very narrow. V junction, laminofacetal junction is a very small thin plate, around 3 to 4 meter bone you need to drill and you just go there. Again, ligamentum fleum is sometimes very absent or may not be very thin ligamentum fleum. Root manipulation, it's like you are just sliding or you are just flowing with the scope and flowing with the scope and your instrument. Again, small incision, sometimes you can remove the central disc because of scoping angle, 30-degree angle. In a monoportal scope is almost a 10 to 15 degree stenoscope. So you have 30-degree angle allow you to go inside the disc. Here you can see this video. Once we remove the disc, then with the special root sleeve, we can go inside and can remove the central part of the disc also. So it is very easy to remove with a sleeve and can easily decompress the central part also. If that herniation is in the center and it has connection to the foraminal type also. Again, a removal of the contralateral disc is very easy with the smaller scope because you can easily maneuver your cannula, and again your cannula act as a retractor, smaller cannula, but larger cannula to put the contralateral side is very difficult. So here I am going on the contralateral side and just retract the cannula and I go contralateral disc. And we just approach the contralateral disc, just RF and remove the contralateral disc is very easy. Again, but in the thoracic spine, instability is not that big issue. So when you remove the thoracic OPLL or thoracic OLF, it is a larger scope I would recommend because you can do very fast bony work, and here the time also matter. Thoracic spine you have to do very quick because water flow pressure cord cannot be tolerate longer time, so it should be very fast. Contralateral exiting nerve root decompression is very easy with the thoracic scope because we go below the pass. Here you can see the up and down migrated both side disc is there. So I did contralateral interlumbar with a scope in scope, smaller scope. You see the exiting nerve root nicely visible with a smaller scope, but when you go larger scope is very difficult. Here pedicle and go below the pedicle you can see traversing scope with the same scope on the contralateral side, but larger scope will not allow that much of movement. Again central disc. So when the disc is very large in the center, you can easily retract with the scope, and you can see even in the C-arm, you can correlate well with the C-arm. Just few moments. You can see almost we are reaching on the contralateral side. So that's very easy. Again, cost is the monopodal scope are costly, but I use the transforaminal scope for all the smaller scope work. We don't need again extra scope, and one scope for that stenosis. Again, transforaminal scope is transforaminal surgery. Stenoscope do all the stenosis work, but a smaller scope always preferable for the discectomy. Cervical discectomy, I use small scope, contralateral, smaller scope, cervical lumbar and thoracic stenoscopy. Larger scopes are the better. Thank you.
Thank you, Dr. Bhupesh. We now invite Dr. Karthik Kailash to give his talk on interlaminar versus transforaminal approach.
Good morning, everybody. And at the outset, thank you, Arvind and Ayush, for putting up a fantastic show here. I think probably one of the more grandiose MISSAB cons we've seen in recent times. Thank you very much for that. My premise is that we have to talk on root decompression, the need for interlaminar versus the transforaminal. So, why does we talk about pathoanatomical changes initially, we do herniated disc, osteophytes, hypertrophic flavum, or foraminal narrowing. And of course, the pathoanatomy indicates that there could be exoplasmic impairment, impaired neural function, mechanical pressures, sensitization, and inflammatory process, along with Valerian degeneration, which could be a cause for our root compression, as we all know. Now, why do we need to decompress first? Or is there medical management going there? We need to restore neural function. We need to get minimally invasive technique, and it's patient-centric, all because we want to restore the pathoanatomy as normal as possible. Now, coming on to transforaminal, this came in as a first introduction right in the early 90s with Martinide, Anthony Young, etc. doing it, and then Gori pushing it off here in India. Now, we wanted to see everything to be safe. So we had the scope put in to see the root as well as everything. And we also wanted to choose the safest corridor. So transforaminal was, let me reach the problem side without disturbing anything else. And this also was done in a minimally invasive as well as on a local anesthesia. And this gave us a perfect idea of approaching the nerve for doing a decompression. But can we achieve all the root decompressions with this? No. There are some problems, we'll come to it. Now, once we decided we could not reach everywhere with the transforaminal scope, we had to find some alternative mechanism, and then we decided we had to do interlaminar endoscopy. And this was a minimally invasive corridor with maximal visualization right through the center. The advantage being that we are used to this kind of technique day in and day out doing microdiscectomies. So here the pathology was right in front of us, so we saw, let me go in and see the problem directly rather than an indirect method like in the transforaminal. So why did this come about? Because we had problems with transforaminal. We couldn't see everything. High iliac crest was an impediment to reach the L5S1 disc. Revision surgery with foraminal scarring was there. A central or highly migrated disc also did not give access to a transforaminal scope. Of course, the experts like Bhupesh and others who are here, they will say that, yes, we can achieve everything through a transforaminal, but not in my hands. So what are the basic principles? When you look at the philosophy, the interlaminar was midline, the transforaminal is a lateral, visualization is inside out, as well as the transforaminal could be outside or inside. Either way can be done. The biomechanical impact was slightly higher risk of destabilization, while transforaminal definitely preserves the stability. The surgical mindset of the surgeon is very important. In the interlaminar approach, most people are doing that now because it's a microdiscectomy mindset, while the transforaminal approach is a percutaneous interventionist approach, and the anatomical orientation is a little more difficult and orientation is a little more hard there. So look at anatomical considerations in doing and approaching this. An axis root is between the lamina and the interlaminar with a cabin triangle of the foramen. The narrow interlaminar space, the upper levels, makes it a challenge, while facet hypertrophy, iliac crest, and L5S1, all these make it a problem for us. And indications also, what type of a disc also is a different parameter for us. So when you look at what are the best levels, the L5S1 level, you have an interlaminar approach being the easiest, while the L1 to L4, those levels above are the easy for transforaminals. Of course, anatomical considerations, most importantly, we felt doing under local anesthesia was the best modality for us doing transforaminal. Others have switched on to doing GA. While radiation exposures are usually higher for us in transforaminal because the number of shots we need to take. Phlegm is usually preserved in the transforaminal, while it has to be split or dissected out in the interlaminar. And of course, neural retraction or visualization of the root is definitely possible in both techniques. Now, when you look at consideration of this, you have to look at what type of herniation, etc. And we also have to look at the X-ray as well as the patient-specific factors. So when you look at root, what level it is, when you look at the shoulder level, it's most probably a transforaminal approach for decompression, while in the axilla and the saddle, it's more the interlaminar, which is more feasible across. Now, when you do a transforaminal, you want to look at the type of the disc. You have foraminal, foraminal stenosis, lateral recess, central, and herniated nucleus. While in the interlaminar, it's the axillary or the central or the up migrated. Migrated discs are very difficult to approach for some of us who are in the initial stage of endoscopy to do with the transforaminal route. Anatomically, the higher the iliac crest, the more difficult it is for transforaminal, so avoid it in the beginning unless you want to do a transiliac procedure. So if you have previous laminated defect, transforaminal is much more easier to approach as compared to a interlaminar technique. MRI, you have to look at it very carefully to decide what kind of a disc is there. Again, the more tighter the foramen, the more severe degeneration interlaminar becomes more feasible as compared to transforaminal. Patient-specific factors, again, obesity makes interlaminar easier. Tall patients, interlaminar feasible. High cardiac risk, low anesthetic risk, you could do a transforaminal. Severe OSA is transforaminal. Pulmonary reserves, again, do a local and transforaminal. So for my choices would be, if I'm doing a transforaminal endoscopy, I'll do it from L1 to L5, paracentral nuclear disc, far lateral or extreme lateral approach for this. Interlaminar, I'll do it as central, paracentral, up-down migrations, and L1, L5, zone 1 higher. And this algorithm is essentially for people who are starting endoscopic surgery in front of us. So when you have an L5S1 level, it's migrated, you do a transforaminal, and if it's very highly migrated, do an interlaminar. Thank you very much for the patient hearing.
Thank you so much, sir. I request all the speakers to come in the front so we can take all the questions as well. And we now open the floor for discussion. I'll just start with, would like to ask Dr. Warawat, in your study, have you taken into consideration also the positioning of the patient? Is Dr. Warawat here? Oh, I think he's left there. All right.
Yes, Dr. Pushkar, nice presentation about deciding which approach. But what are your criteria in multi-level cases? How many levels you would like to address based on pure radiology or based on clinical? Or
it's always both, sir. We don't treat images. It's the symptoms that we see first in our OPDs and match it with the MRI. So if we can see, as in the cases we discussed, that the patient had only a right-sided symptoms, and L3-4 only left-sided symptoms in the particular case that I had discussed. Patient has a right level lateral recess stenosis also, but we skipped that.
Yeah, Pushkar, just as an extrapolation to the question,
Yes, sir.
now in multi-level stenosis, there could be more than one pathology, right? One trigger which is causing the pain. So how do you know when the patient has got more than one trigger or one site? Do you subject any of these patients to injection studies to actually diagnose and then go ahead?
Sir, we definitely do injection also when it is required. We discuss it with the patient also. If there is a disc herniation at 2 levels, or if we are confused that maybe one of them is not so much causing the symptoms, we can subject the patient to injection also.
So in how many of these patients have you actually subjected the, given injections and then made a clinical diagnosis before you go and decompress symptomatic levels?
In few probably, sir, but there's no documentation as such, particularly how many cases we did that. But in our routine practice, we do subject patient to injections.
Yeah, and most of these degen patients, there could be some sort of hidden instability. So how do you rule out that instability, translational as well as axial instability before deciding on only decompression?
We do dynamic X-rays in all the patients, sir. Standing, flexion, extension in all the patients to see if there is instability or not. So in the exclusion criteria, instability was excluded from the study.
Any more questions? Yeah, Akhil? Yeah.
Hi, nice presentation, Dr. Pushkar. So just wanted to know, so that's a great algorithm that you have,
yes,
the FAPDIS, but any need of CT scan as well? Do you think that would probably change some of the scoring? Or have you felt the need that probably should have also gotten a CT scan done?
Yes, a CT scan is definitely helpful in interlaminar as well as more in transforaminal cases when there is a hard disc, then it is very difficult to deal with it, or we have to be prepared for it. So in such cases, again, if it is a hard disc, if it is far dorsally migrated, so it fits more into interlaminar decompression than transforaminal. So it helps in that way also. But yes, definitely CT will help in certain cases to see if it's a osteophyte or a hard disc rather than just a juicy or a soft disc.
Yeah, Dr. Satyan?
Yeah, question to any of the speakers, in fact all of you all. For central disc herniations, large central disc herniations, do you normally use your interlaminar scopes, and if you do, any pointers as to how to safely remove it? What challenges do you face in those cases?
So especially central disc, in higher lumbar level, we usually prefer transforaminal approach. But in L4, 5, L5, S1, we can, I usually do the interlaminar approach. Yes, but first we need to start from the more laterally. Then gradually you just rotate the cannula and gradually you go more medially towards and identify the edge between PLL, posterolongitudinal ligament, and disc and thecal sac. Then you use very curved instrument or angulated instrument. Gradually you remove the central disc, and along with you take 1 or 2 Siam suit. You can see how more centrally you are going. And I have done almost 15-20 cases of central, very large central disc, and we are able to remove. We do all the patient post-op MRI. We are able to remove the entire disc which is bulging out in the epidural space. But you need to, very controlled manner, you have to go more medially. Once you remove the disc volume, then go little medially. Once remove the disc volume, then go medially. Directly don't push because the thecal sac is very much dorsally here. So it is dangerous. Once you remove significant amount, then proceed towards the center.
How often do you need to convert it to open?
I have not need to convert any open, yeah.
See, one more difference is, Satyan, that when we do a discectomy with endoscopy, our aim is not to remove the whole phlegm. We just make a rent in the phlegm and go in. But in a central disc herniation, we have to make sure that you do a thorough decompression. You remove the phlegm medially, laterally, maybe make a bigger window with some bone burring, and then you retract. So there, in those situations, we have to do a thorough decompression, and then you go and remove the disc, and not go very minimal.
And how are there any tips to getting the neural retraction to see how easily it is moving? Is it easy or is it?
Yeah, so that another thing we try out. So sometimes there are adhesions. So with the RF, we remove the adhesions laterally, and then with the pen-filled dissector, you can start moving the nerve root medially. We don't go and rotate the cannula initially. Otherwise, it can cause a lot of damage.
Yeah.
So use the pen field and slowly, steadily you start dissecting and you start going medially. Once you realize that the nerve is quite free and tension free, only then we rotate the cannula. Now in cases where we are not able to medialize the nerve that much, then obviously you use your nerve hooks, or you go more medially, remove more of the phlegm, go over the top type, and then try and retract the nerve. But first, always pen field, dissect it, try and feel how strong it is to retract, and only then turn the cannula.
Yeah, but transforaminal, I think it's quite easy to remove because you land more on the medial pedicle line, and once you put your instruments, you're right there. So, and there is no retraction involved, and it's basically, it's totally a bloodless field, and it's quite easy to remove a central paracentral disc.
My only worry was that we are not able to actually see whether the neural structures are actually decompressed in the transforaminal route for these cases. So,
No, you have to see the free floating thecal sac. Otherwise, you don't stop your surgery. But again, when you are dealing with the calcified disc, so I think there are a lot of paper. When we are dealing calcified disc, lower lumbar level, you should try to remove the calcified fragment as far as possible. But higher lumbar level, you just need to decompress both root. That's it. Otherwise, you may end up with the neurological consequences. In higher level, don't attempt with the calcified disc.
Yeah, one question to all the panelists, to the speakers. When do you decide, when you have compression all throughout, and you have to combine both the approaches, the interlaminar and the transforaminal, how would you decide which one to do first, and when do you take the call of doing both together? Is it pre-operative planning, or you do one and then decide, nahi, abhi decompress nahi hua, I will go and do the other way? So, Dr. Ravindranath, if you can take the question.
Two approach combined when you decide.
So basically, using the algorithm, what we generally decide is firstly understanding the pathology where it is, what is the dermatomal distribution. Also, the decision to decide whether which approach to take has to be preoperatively, because that choice of anesthesia will also depend on it.
See, my question is very simple. Suppose the patient has got a lateral recess stenosis with a superadded disc.
Yes.
Right? The patient already had a pre-existing lateral recess stenosis. Now there's a fresh disc.
Yes.
Now, how will you decide whether you want to remove only the disc or you want to decompress the lateral recess also?
Yes.
Because you don't know which component is giving how much pain.
Yes.
Yeah.
At least I know which nerve root is getting affected. I would address both the pathologies if I'm definitely addressing it. If it's a foraminal herniation, for example, and there is a foraminal part of the ligamentum flavum also affecting it, if I can address it transforaminally, addressing the disc part of it, and then go from the other side, do an ICLF and address
So you would do one and then going for the other,
yes.
right?
So, but in this case, if I'm going transforaminally, I would rather go for an epidural analgesia, so that I want the patient in local anesthesia. So I will do the interlaminar also in epidural.
Also, I want to add.
In such cases, when we have combined foraminal or lateral recess stenosis, I go over the top decompression, remove do the both root decompression in the single incision over the top. That makes very easy. If along with the lateral recess and disc herniation, remove both. Why we want to take chance? If both root if we have significant stenosis is there and disc is there, then remove both. Whatever possible, the root decompression has to be there. If there is no root decompression, if you leave the ligamentum flavum and just remove the disc, after few months or few years, patient will come back with the stenotic symptom.
Also, in different levels, sometimes 1-2 is there where you want to go transforaminal, and 4-5 where you want to do some interlaminar work. It's okay to do surgery under general anesthesia, and there is no issue. Just it's about your experience. And with my experience, I can tell even interlaminar surgery is also very well tolerated by just pure local anesthesia. It's about your surgical time, how much patient is able to tolerate in prone position in awake situation.
Yeah, thank you. Can you have the question? Can you introduce yourself and then ask the question?
Hi, I'm Dr. Rahul Rane. I just want to ask, in transforaminal we require a lot of shoots. So what are your tips to reduce the shoot?
Yeah, I think that's good. That will go with your experience. Initially, as a learner, as a beginner, you will need, because you need to be very precise with your needle, with your instruments. So initially, you might take a little more shoots, but then over a period of time, I think it's a matter of your experience. You are improving your skill set. You will need very fewer. Once your needle is inside and your scope, your cannula is inside, then after that, I think you don't need any shoots at all.
When beginner will start with the transforaminal endoscopy, so you just decide your trajectory. When you are doing the lower lumbar level, you're around 15 degree. So you start with needle 15 degree. First bony resistance you encounter, just take one shoot. Before that, you don't need any shoot. And then take lateral shoot and just correlate with the AP and lateral anatomy. AP, you need to stay in the lateral facetal line. In the lateral, you need to stay in the posterior laminar line. So once you see the V junction, you stay your needle in the V junction, just elevate the, just remove the needle bit and elevate and go grazing the facet, just go below, and just you need only 2 shoots. So total 5 to 6 shoot, you just land inside the disc. So first bony resistance you have to encounter. That's it.
Just a small addition. So for reducing the shoot, we can make it a practice that all the blocks that we give it through a transforaminal axis or the long needle, that the entry point that we usually use for transforaminal endoscopy. So we are more used to it and dealing with the approach and needle handling, so that will eventually decrease the number of shoots that we require during the table while doing the transforaminal decompression as well.
Yeah, Dr. Harshvardhan Avrane. So I have a question for first 2 speakers about the Fapodis algorithm. Does the Fapodis algorithm applies for upper lumbar spine? Because there is a significant difference between the interlaminar window and the disc height or disc level. And does the breadth of the pass is considered? These 2 things are not considered in Fapodis algorithm for a particularly upper lumbar spine.
So Fapodis is for lumbar. It includes the upper lumbar. In upper lumbar, facet inclination is more, the facet are more sagittally oriented. So automatically it favors more towards transforaminal. It gives more score to transforaminal endoscopy. And other pathology also, if we calculate, it usually will lean towards transforaminal endoscopy.
Yeah, but in upper lumbar spine,
Yes.
the facet is not the bony landmark which will be hindering your way. It mainly the pars, because the interlaminar window is much at the lower level as compared to the disc head. So how you will decide whether to go interlaminar or the transforaminal in the upper lumbar spine? Lower lumbar spine, it's okay. The facet will be the bony part you are facing it. But in the upper lumbar spine, the whole part will be the bone only. So how you are going to decide it, whether to drill pars or whether to go transforaminally? That is my question.
So in upper lumbar also, our docking point is usually the 12 o'clock position of the pedicle SAP junction. So we have to do the decompression through the foraminal route only. So we land at the 12 o'clock position of the pedicle, we burr the SAP and go cranially, caudally, depending on the pathology that we want to deal with.
Okay, thank you.
Yeah, one question for Dr. Bhupesh. So you showed us a lot of inventory about the scopes and the variations in that. And sometimes if there's a lot of menu on the buffet, it becomes difficult to choose what to eat first. So if you were to recommend for the beginners, 2 scopes, one is the interlaminar and the transforaminal.
Yeah.
What would be your choice?
So I would recommend that if beginner start with the endoscopy, he has to attempt only discectomy. So for that matter, he should buy the transforaminal scope. So he can do transforaminal endoscopy and L5S1 or L4-5 large interlaminar endoscopy. Once he acquainted around 50-100 cases, we do the discectomy. If we want to progress further with the stenosis, then he can buy stenoscope. But initially with the transforaminal scope, you can do both transforaminal and interlaminar, both endoscopy. But if you buy stenoscope, then your transforaminal option will go on. So you can only do with interlaminar endoscope.
Dr. Sandeep, if you can conclude.
Thank you.
Thank you all the speakers.
So thank you. I'll just conclude the session. So basically we saw that there are multiple ways of doing a lumbar disc. We all have been used to open, but the basic thing is that we need to remove the disc fragment, make the nerve root free, and there are multiple ways in which we can do it. However, the pendulum is slowly shifting towards MIS and endoscopic, and if we look at the crux of the whole talk,
here are the 6 points that we can go through. Why? Definitely the pendulum is swinging towards endoscopic and minimally invasive. As you can see that the attendance in the hall in the minimally and the endoscopic session is far more than the open surgeries. And also it's a good marketing tool for you to market yourself. There is an increase in the academic interest as seen by the number of publications which are coming in the endoscopic journals. We all went through the algorithm which was mentioned by Dr. Patgaonkar. There are multiple algorithms which are there, meta-analysis studies, but basically what the take-away message is that if it is higher level targeted approach, go in for transforaminal. If it is alpha S1, then probably you can go in for interlaminar, which is a much safer approach, less radiation as compared to the transforaminal approach. There are various nomenclatures in this. Basically, it boils down to two things. One is again the approach transforaminal, interlaminar, and then again whether it's a discectomy, a global decompression, or a fusion. So these are the terms which are used. Advantages are obviously it's a less minimally, it's a endoscopic approach, less invasive, less blood loss. It has got a longer learning curve. As was mentioned by Dr. Bhupesh, there is a lot of inventory available on the, if you actually go through it, and you really have to decide what you want to use. There is a definite functional recovery as far as short-term results are concerned. The literature is very clear in this. There is no added advantage of an endoscopic over a minimally invasive if you look at the long-term results. However, the short-term results and the muscle damage and the blood parameters for CPK levels go in favor of endoscopic approach. There are certain limitations, especially at the alpha S1, wherein interlaminar approach is preferred as compared to a transforaminal. So what is the road ahead? Most of the literature now is not a debate about whether it's an endoscopic versus MIS. It is between endoscopic approaches, whether it's a uniportal versus a biportal. And obviously, there are studies which show that in the as we go along, there is going to be a lot of fusion surgeries which are going to happen minimally invasive. So it's better to adapt as early as possible. And obviously, there are newer techniques which will come in like robotics and AI, which will definitely aid us in doing this, in carrying out this endoscopic procedures and go ahead. Thank you very much. And I thank my co-moderator and all the panelists and the speakers for having a wonderful session. And I hand over this session to the next speaker.
Thank you, everyone. We'll conclude this session.